Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Today's program is part of our Cancer Center series, a special collaboration between the Blum Center and Mass General Cancer Center. Before we just get started, I just want to go a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has muted so we can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I would like to introduce you all today's guest speaker. Joining us today, we have Laurie Miller. Laurie is a nurse practitioner in the MGH gastrointestinal oncology, whose primary patient population is those diagnosed with pancreatic cancer. In recognition of Pancreatic Cancer Awareness Month, she joins us today to give a talk on pancreatic cancer. So please join me in welcoming Laurie.
Thank you so much. Appreciate that. I would like to let me go ahead and share my screen. Can everyone see that? Can you see that, Amy?
Yes, just not in the presentation mode
I'm going to flip into presentation mode here. There you go. How's that? Good?
That's good. Yes.
Right. Great. So thank you for joining. I want to talk a little bit today about pancreatic cancer and what that diagnosis means for you and your family and friends. I know that once the diagnosis of pancreatic cancer is made, a patient and their family really enter a world of unknown. And while navigating treatment options, a patient is really faced with a frightening journey of physical symptoms, changes in lifestyle, and a lot of worry about what the future holds. So today we'll talk a little bit about this journey, and hopefully I'll give you some information that will give you a better understanding of what to expect, and we'll definitely save some time at the end for some questions. So I think it's helpful to start with just a basic understanding of the pancreas, where it's located, and its explanation for, its location as an explanation for a lot of the symptoms that somebody might be experiencing. The pancreas is located, I think I can laser point here, right in this area here. Hopefully you can see this on my screen. It's located just behind the stomach in the upper abdominal area, and it stretches really from the left side over to the right side. And that really helps explain why patients are having pain in their upper abdomen. On the side view, you can actually see this cross section of the pancreas, and you can see this very large duct sort of in the middle of the pancreas. That is the pancreatic duct, and that carries a lot of hormones and digestive enzymes. There's some smaller ducts which also drain bile. And if these little ducts get clogged, either with, usually with a compression of a tumor that might make them more narrow, then this can really affect liver function. There can be a backup of bile or pancreatic enzyme. And that's when typically you'll see liver dysfunction and people actually becoming jaundiced. There's also some nerve fibers that are located behind the pancreas area. And these get compressed, especially when people are laying on their back. The pancreas will kind of push on these nerve fibers, and pain will typically be worse when you're lying flat because of that pressure. on the inflamed tissues and on the nerve fibers. So that's just a very basic general overview about where the pancreas is located and some of its functions for carrying hormones and digestive enzymes and bile. My screen literally is completely frozen right now. I'm so sorry. Let me just sneak out of here for a second. I'm so sorry. I have like frozen screen. Go. Okay. So why is the pancreas important? There's some major functions of the pancreas, and they are involved in digestion, and they're also involved in insulin production. So the first function of the pancreas is what we refer to as an exocrine in helping us to digest the foods that we eat. Maybe or maybe not, you've heard of amylase and lipase as the hormones that are the digestive enzymes rather that help us digest carbohydrates and fats, trypsin, which helps us digest proteins. And when we have disease in the pancreas, there can be a reduction in the amount of enzyme production that's happening in the pancreas cells, leading to worsening digestion. This can cause a lot of symptoms of bloating, gas. People will have a lot of intestinal cramping. Very often they might have these symptoms in correlation to their meals, usually within an hour of eating. They might find themselves having to go into the bathroom to relieve their bowels, typically with very loose stool. The endocrine function of the pancreas plays a role in the secretion of two hormones called glucagon and insulin. And these hormones really are responsible for the production of insulin and blood sugar control. So when there is dysfunction in the pancreas, very often people will have difficulty regulating their blood sugars, in part because one, they might not be secreting enough insulin, or they don't have enough glucagon to help the insulin work effectively. So patients can often be suddenly diagnosed as being hyperglycemic or having elevated blood sugars where they were never diabetic before. So that can sometimes be an initial indication that something is happening in the pancreas. When we look at pancreas cancer by the numbers, this is just taken from the American Cancer Society. These are statistics as of this year. It is the fourth leading cause of cancer in the nation. Approximately 66,440 will be diagnosed with pancreatic cancer. You can see it's a little heavier in men than it is in women, 34,000 versus 31,000. Approximately just over 51,000 people will die of pancreatic cancer. Again, a little bit more predominance in the men versus the women, partly because they have a higher rate of diagnosis. The lifetime risk of someone acquiring pancreatic cancer is about 1 in 56 for men and about 1 in 60 for women. And this can be affected by a number of risk factors, which we're going to get into a little bit of the risk factors next. In addition to these statistics, in terms of age, most cases will develop between the ages of 60 and 80. Although I personally, in my own practice, have seen patients as young as their mid to late 20s, although that's not all that common. And I also treat a few patients, many patients actually, over the age of 80. In terms of race, African Americans do have a higher incidence of pancreatic cancer than Caucasians, Asians, or Hispanics. And then let's talk a little bit about some of the risk factors, because one of the first questions that I often get when people are diagnosed with pancreatic cancer is, how did I get this? Could it have been prevented? What could I have done to try to prevent this? And there are some risk factors that are modifiable, and there are others that are non-modifiable. So starting with the ones that we can't change or are non-modifiable, This includes things like our family history. There is a familial component of pancreatic cancer in about 10% of cases. If you have a first-degree relative with pancreatic cancer, this will increase the risk by 4.6. If you have two first-degree relatives, this will increase the risk by 6.4. There can be genetic mutations, which only account for about 10 to 15% of pancreatic cancer, but it is a screening that we will put our newly diagnosed pancreatic cancer patients through to determine if they have any of these genetic mutations. Some of them you're probably familiar with, like the BRCA gene, which is common in breast and ovarian cancer, can also play a small role in the risk of pancreatic cancer as well. And then, of course, some of these other genetic mutations, maybe not as commonly known, but certainly can be an increased risk for pancreatic cancer. And then looking at risk factors that we have some ability to control, that could, certainly if we did control them, we could reduce the risk of pancreatic cancer. And the first one is tobacco use. Smoking is one of the most important risk factors, and the risk is twice as high. The risk for pancreatic cancer is twice as high in smokers versus someone who has never been a smoker. And this is true for traditional cigarettes, also cigars, and smokeless tobacco products also increase risk. Obesity is another one of those risk factors that is considered modifiable, although I know some might argue with the fact that it's not modifiable, and there may be some genetic predisposition to obesity as well. But what we do know is that patients with a BMI that is greater than 30, they are 20% more likely to develop pancreatic cancer. And then diabetes, it is more common in patients with diabetes, especially if they have a type 2 diabetes. However, I would argue a little bit about cause and effect. Is it somebody who is maybe in their late 40s or early 50s, suddenly having issues with high blood sugar, subsequently being diagnosed as being diabetic? But what came first, the chicken or the egg? Is this an early sign that they're developing some sort of a pancreatic disease? Or is the diagnosis of diabetes subsequently leading them to a cancer diagnosis later on? And then chronic pancreatitis. Pancreatitis is often seen in patients that have heavy alcohol use and or smoking. And this is a chronic inflammation of the pancreas over time, typically over years, that can increase the risk of developing pancreatic cancer. And then in terms of unclear risk, these are factors that are also somewhat modifiable, but the true risk of these has not quite yet been determined. And your risk for then developing pancreatic cancer. And those things include diet, red processed meats, saturated fats, and sugary drinks, physical inactivity. Alcohol in limited amounts has not been established as a clear risk factor. Coffee, there's some conflicting data about whether coffee can increase one's risk for pancreatic cancer and certainly other illnesses as well. Aspirin, the use of non-steroidal anti-inflammatories, there's conflicting data about the risk of this as well. Patients diagnosed with H. pylori, which is just an overgrowth of normal bacteria in the gut, also some conflicting data about whether this plays a risk or not. And then industrial chemical exposures. Again, this is an unclear risk because some go on to develop cancers and others do not. I think that the bottom line and the message here is that leading a healthy lifestyle can certainly contribute to your overall health and reduce your risk, not only for pancreatic cancers, other cancers, and certainly other diseases as we age. So how does pancreatic cancer start? What is actually happening when this disease begins? And this is really related to very small changes in our DNA, our genetics, our cellular DNA, which results in this sort of uncontrolled multiplication of our cells and this accumulation of this overgrowth of cells in clusters that eventually become tumors. And if untreated, these cancer cells can spread outside of the pancreas to other parts of the body. And we'll talk a little bit about that later as well. So there's different types of pancreatic cancer. I don't know who we have online here or if any of you have been diagnosed with pancreatic cancer, but it is a little bit helpful to know the type. Our exocrine cancers, just referring back to one of the slides we mentioned earlier, the exocrine function of the pancreas being that of the secretion of the digestive hormones. So these particular cells, called exocrine cells, are an area where we can develop pancreatic cancer. They can be ductal adenocarcinoma, which accounts for actually more than 90% of the exocrine cancers. We refer to it as PDAC, PDAC, pancreatic ductal adenocarcinoma. So, if you are a patient and you've seen that terminology in your charts, that's what it's referring to. Again, found in the abnormal exocrine cells. Acinar cell carcinomas account for about 1 to 2%. Squamous cells, again, about 1 to 2%. Adenosquamous, 1 to 4. And colloid carcinomas, about 1 to 3. And the different names on the slide really just referring to the type of cell where the abnormality is. So those are exocrine cancers. Neuroendocrine cancers really account for just a very small percentage of pancreatic cancers. And these usually are islet cells where this endocrine function, this production of the hormones secrete a variety of peptides, including insulin, gastrin, glucagon, these vasoactive peptides, and they all result in like a variety of clinical syndromes. And I would say the majority, 50 to 75% of these neuroendocrine tumors, these NET tumors, really are non-functioning. And they're much more rare, they're less aggressive, and they're definitely more treatable if they're caught early. So what does somebody look like when they're, beginning to get sick from pancreatic cancer? Very often, and I hear this story a lot, patients have presented to their primary care doctor. Maybe they've had some vague abdominal pain. Maybe they've had some vague back pain. Their appetite is not as good. They're losing weight, but they're not really sure why. Or they're eating fairly normally and they're losing weight. They might have some vague nausea, or they've even had symptoms of like acid reflux or burping, and just have felt differently than they normally would. In some situations, patients actually present with jaundice, which is that yellowing of the skin and the eyes that you see when those small ducts that we looked at in the pancreas back in like slide 2, when I showed you where those ducts are, they're getting narrowed or blocked off because of tumor, and they're not draining bile appropriately the way they should be. That bile is backing up, it's causing liver dysfunction, and people are developing jaundice. They may have this progressive back pain that radiates around the abdomen, again, because this cluster of cells is growing inside the pancreas, and it's causing pressure and pushing on some of that nerve tissue that's behind the pancreas that radiates around into the back. Anorexia, they may have weight loss, they may have some nausea or vomiting. And this often can get attributed to just symptoms of GERD or acid reflux. They may have signs of pancreatic insufficiency. So pancreatic insufficiency being those symptoms we talked about earlier, like gas, bloating, intestinal cramping. They're eating, and within an hour of their meal, they're just, having all of these symptoms, having a lot of pain, which is preventing them from eating more, and hence their appetite goes down and they're losing weight. So it almost becomes like a vicious cycle. They may have some duodenal or obstruction in their gut or in their bowel from the tumor that's beginning to grow, and they may have more difficulty moving their bowels, more constipation. Um, they may even have diarrhea, especially if they have this pancreatic insufficiency and don't have enough digestive enzymes to metabolize the food that they're eating. If they had diabetes prior to this, maybe they're noticing that all of a sudden they had great control of their blood sugar up to this point, but now it's getting harder to manage and they're needing more and more insulin. Or they're just being diagnosed with diabetes initially, whereas prior to this, they never had any issues with their blood sugars. And interestingly, cancer can put us at increased risk for blood clots. So they may present with a blood clot in the lungs or the legs. Maybe they developed some acute swelling in the leg for some unknown reason. Had it checked, they did an ultrasound and found a blood clot. So that simply can just be because of the increased risk that cancer gives us for developing blood clots. So someone presents with all these symptoms. If they haven't gone to primary care, or if they're just coming to us for a workup, one of the first things that we're going to do is a CAT scan, and this is going to include a CAT scan of the chest, the abdomen, and the pelvis. Well, someone might say, well, why do we do a CAT scan of the chest? Well, we want to make sure that if this is cancer and that we're finding it in your abdomen and your pancreas, it hasn't spread anywhere else. And we'll talk a little bit about metastasis and cancer spread in a little bit. But that's going to be one of the first tests that we get, is a CAT scan of the chest, abdomen, and pelvis. Sometimes we'll get an MRI, not always. It's not always needed for the initial staging of pancreas cancer. We do get MRIs if we find cancer spread into the liver and we need to do a better evaluation of a liver metastasis. We can do a liver-focused MRI, but often the CAT scans are yielding us enough information to confirm a diagnosis so that at least we can get somebody started on treatment. You might have an EGD, esophagogastroduodenoscopy, or an endoscopic ultrasound, an EUS. And these are done, this is a procedure done in a suite, an interventional suite, where they would do a scope down your throat. People would receive some sedation for this procedure. And this helps us to stage the tumor. We can get a biopsy from it so that we can confirm what it is. We can at the same time do what's called an ERCP, which is a procedure that puts a small stent in one of those ducts that I showed you early on. If someone is developing some biliary or bile obstruction in those ducts, we can actually go in during the EGD and put a stent in there, so we can open it back up and improve liver function. We can do a fine needle aspiration of the biopsy, which is basically a fine needle aspiration, and send the mass down to pathology to again confirm what it is. And then a PET scan. Patients often ask us about PET scans. They're done only in selective cases because they don't often add a lot of information in terms of getting someone started on treatment. We do sometimes subsequently send people for PET scans, but they're not generally part of the initial workup. And then we're also looking at things that we refer to as serum tumor markers. Serum tumor markers, I like to think of it, the best way to explain it, as genetic material that your cancer cells are secreting. One being the CA19-9 that we'll measure. And this is a very specific pancreas tumor serum marker. So if we draw your blood and measure the amount of CA19-9, our genetic material that's in your blood, it can give us an indication over time if we follow those numbers, sometimes monthly, sometimes every other month, to give us an indication about whether we have control of disease. And the CEA is also a tumor marker. It's less pancreas specific. It's more of a general marker. We get it, but it doesn't always give us a great indication about what's happening in the pancreas. Staging, I touched briefly on staging. There's a lot of information on this slide, and I don't really want to overwhelm or give too much information about staging. However, let me simplify it a little bit. Staging is really determined by what's called the TNM system. So the T refers to the extent of the tumor, how large the tumor is, and whether or not it's grown outside of the pancreas into nearby blood vessels. If anyone is really closely looking at this slide, you can see the different measurements of the tumor and how you might classify it from a T0 up to a T4. The N refers to whether or not the cancer has spread to any lymph nodes. So again, how many lymph nodes have cancer is how we sort of categorize the N grouping. So an N0 would be there's no regional lymph node metastasis, all the way up to an N2 where you have maybe some metastasis in 4 or more of the lymph nodes. And then the M in the TNM refers to whether or not we have distant metastasis. And distant metastasis, I mean outside of the pancreas, outside of that organ, and away from those small blood vessels into maybe the liver or the lung. Those would be the two most common places for pancreatic cancer to spread. So it's the TNM staging system that we use. And then we talk about resectability and whether pancreas cancer can be surgically removed. So when we think about surgery for this, we're looking at things like, one, the staging. If someone is resectable, these are tumors that grow right within the cells of the pancreas. You can see on the slide here that it's a very localized area within the pancreas and typically is surgically operable. In a borderline resectable or a locally advanced cancer, this would mean that the tumor sort of abuts or lays adjacent to, you can see the major blood vessels there in blue and in red, and whether that tumor has just, kind of grown and is laying right next to them, or in some cases has actually wrapped itself around those blood vessels. And this makes surgery on these kinds of tumors a little bit trickier because, of course, we're talking about major blood vessels and any impact on those could be life-threatening. And then in metastatic disease, you can see the tumors. This is the liver in gray up at the top, and the growth of the pancreatic cancer into the liver essentially would mean that we would not opt for surgery at the forefront. That doesn't mean it wouldn't be considered later on down the road, but typically we're talking about treating with chemotherapy for an extended period of time. So in looking at just sort of the goals of disease that might be amenable to surgery, locally advanced, the treatment goal is really a curative goal with the aim of getting the patient to surgery. The rates of recurrence, even after an R0 resection, are still very high. It's still at about 80% for systemic recurrence, with a 20% local recurrence. This argues the rationale of providing somebody with chemotherapy before they go to surgery, which is pretty much the standard of practice here at MGH. Some upfront chemo before getting someone to surgery, just to address any micro cells that might be trying to metastasize, but we haven't really seen them yet in your workup. They're not really showing up, in your chest or in your liver. But some of those cells might be trying to break off of the pancreas. And this, sort of adds evidence to why we would treat somebody with chemotherapy before we sent them to surgery. So there is a higher chance of receiving systemic therapy preoperatively because of this reason. Outcomes. The 5-year survival rate of patients with pancreatic cancer, this is based on data from 2013 to 2019. For localized, it's about 44%. So definitely less than half will live past that 5-year marker. If they had some regional metastasis, lymph nodes, adjacent blood vessels, it's about 16% 5-year survival rate. For patients with distant spread, the 5-year survival rate is about 3%. And if you combine all the averages, about 13% for a 5-year survival rate. And although that sounds grim, there are lots of clinical trials that are happening here at MGH and around the country that are looking to improve these survival rates. And some of them are actually showing some promising results. So let's talk briefly about localized disease. And this would be, planning on getting someone to surgery. Our treatment approach would be chemotherapy upfront, neoadjuvant, meaning they're receiving this chemotherapy before they go to surgery. There's 2 standard of care treatment options, the first one being FOLFIRINOX, the other one being gemcitabine and Abraxane. And the treatment choices are based on a number of landmark clinical trials that have happened over the last several years. And the data shows us that these 2 regimens are yielding the best results. So with FOLFIRINOX, patients get 4 cycles of treatment every 2 weeks, every staging scans to make sure that we're not seeing any kind of further spread, that are, the disease we already know about isn't growing anymore. They get 4 more cycles of treatment over 2 more months. They get scans again, then they move to radiation, and then ultimately surgery. So it takes about 6 months of pre-surgical intervention before we get them to surgery. And then same thing with gemcitabine and Abraxane, couple cycles up front over 2 months. This treatment regimen is given once a week for 3 weeks, and then people get a week off, scans again, 2 more cycles, scans, and then radiation and surgery. Typically, we're measuring those serum tumor markers throughout their treatment. And then if all goes according to plan and we finish radiation and our scans are still showing us that we have stable disease, nothing's growing, nothing's moving into other areas, they head to surgery, they come out of surgery, and at times they will have some post-op, post-surgery chemotherapy. Much will depend on, when the surgeon got in there and took a look around, were there clear margins? Were they able to get it all? Was there some concern that maybe the margins weren't real clear? So sometimes people will get post-op chemotherapy as well. Otherwise, if they don't need that, they'll follow up with medical oncology, our team, for 1 month post-op scans, and then they'll move into surveillance, which includes visits every 3 months with labs and scans for about 2 years. When patients have metastatic disease, the treatment goal is a little bit different. Overall, it's been a little bit of a depressing history with a lot of trials and minimal activity in terms of improving outcomes for patients that have metastatic disease. We do have some trials that are going on right now that are showing some good results, and we are able to give people more time. But overall, in comparison to the research that's gone on in the last 10 or 20 years, there hasn't been much movement in terms of extending that 5-year survival rate. The primary goal of treating patients with metastatic disease is to give them more time by controlling and reducing the spread of the disease. Again, we have a 5-year survival rate of about 2.9%. But to shed some positive note on that, I actually have a patient with metastatic disease right now who's at his 4th year of treatment and is doing remarkably well. I think I have a couple other people that are approaching their 3-year and are doing also remarkably well. So there is hope, and we do very aggressively treat patients that have metastatic disease. The median survival, so on average, is about 6 to 12 months with chemotherapy. But a lot of factors play a role in that number, and that includes your overall health, any other comorbidities that you might have, such as heart disease or diabetes, and most importantly, your tolerability of chemotherapy. And I cannot emphasize enough to people, my patients especially, how important it is to manage side effects from chemotherapy as aggressively as possible, because it will keep you feeling better for longer. And those who feel better for longer tolerate more chemo. It is very important to try to manage symptoms early. Again, it's the same standard of care with metastatic disease, whether we treat with FOLFIRINOX or gemcitabine and Abraxane. Clinical trials are also an option for patients with metastatic disease as well. But there is a process to go through to get accepted onto those clinical trials. So what is FOLFIRINOX? Whether we do this for pre-surgical or whether we do this for someone who has metastatic disease, FOLFIRINOX is essentially the same treatment. It consists of 3 drugs, the first one being fluorouracil or 5-FU. And if there are any patients on here on treatment on FOLFIRINOX, you go home with a pump for 46 hours, and then it either gets disconnected here in clinic, or some patients are trained to disconnect that pump at home. The other drugs include irinotecan and oxaliplatin. This treatment regimen is given every 2 weeks. And some of the side effects can include things like nausea, vomiting, diarrhea, or constipation, actually. So it can be either or. You have to be prepared for both. Many patients will experience fatigue, and some of that is related to just the side effects of treatment as well as disease. There can be loss of appetite. Some patients can get mouth sores or cold sensitivity in their fingers, which is a problem, as it gets colder outside. If you go out, take a deep breath in. Some people will describe it as feeling like they're swallowing shards of glass because of the cold sensitivity. So, there's ways to kind of get around that by wearing a scarf or being cautious about reaching into the freezer or drinking, ice cold water. Neuropathy or long-term numbness or tingling of the fingers or toes can be another risk. Risk of infection or bleeding because we're dropping those good blood counts. And hair thinning. Most patients don't lose their hair on this regimen, but can notice some hair thinning. We often will give a medication called Neulasta, which you may or may not have seen commercials for on TV, and that helps boost white blood cells so that you'll be at reduced risk of infection. And then the other treatment regimen we talked about is gemcitabine and Abraxane. Again, very similar kinds of side effects. Less nausea, some constipation, mouth sores. People can get a little bit of a rash on their skin. Differently, though, than the FOLFIRINOX, people will lose their hair with this regimen. This regimen is typically given 3 weeks in a row and then a week off, as opposed to the full Furanox, which is every other week. But it certainly can be moved to every other week if people are having poor tolerance or they're having difficulty maintaining their blood counts. We don't typically need to use Neulasta with this, but certainly, reserve the right to use it if people are not able to maintain their blood counts. So we did talk a little bit about managing side effects and how important it is to do that as proactively as possible. We give you a lot of these medications for nausea. Zofran, Compazine are two very good chemotherapy nausea medications that our patients can often alternate around each other. We also use a steroid medication called Decadron, and this is typically used for a few days following treatment to help manage nausea. It can help with fatigue. It also can give you a little boost to appetite. And it's really just used those first few days after treatment to help bridge the gap to when you might start to feel better on your own. For the diarrhea, patients are encouraged to use Imodium over the counter. We use prescription directions for Imodium, so your provider will often give you directions to use more than what's recommended on the bottle. And then if the Imodium is not effective in helping to manage those symptoms, Lomotil can be sent by prescription. It's a prescription anti-diarrhea medication. For constipation, we use very common over-the-counter regimens like Colace, Miralax, and Senecot to help our patients manage their diarrhea. Managing these physical symptoms of disease itself is, I think, the most important part of our care. Managing those things like pancreatic insufficiency, which is that altered secretion of the digestive enzymes that I talked about early on, encouraging patients to take pancreatic enzyme. We use Creon, but there's others out there. Zenpep is another one of them. And I typically start my patients on Creon with their meals really at the onset of diagnosis, because I can almost predict that they are going to have some difficulty with digestion. Nutrition consults can also help us manage or make recommendations about dosing with Creon. Diabetes, for patients that are having difficulty with their blood sugars, they typically will require insulin. Anyone who's gone to surgery after chemotherapy and had a Whipple likely will require insulin to some degree afterwards. We can send people for endocrine consults or help with diabetes management, or sometimes there are a lot of primary care doctors that are very equipped to help us manage diabetes. And then the back pain often requires opiates like morphine or oxycodone. Sometimes patients will require long-acting opiate medications or narcotics in order to help manage that. And the other thing that we can do is send them for nerve blocks. Celiac plexus neurolysis or nerve block can help about 50% of the time. So, if patients are requiring more and more opiates, or really just have a sensitivity to opiates and are not tolerating them, but are still having a lot of pain, a nerve block certainly can be an option as well. Weight loss. Weight loss and poor appetite are a very common concern of patients and families. They worry that they're not able to eat enough. They're still continuing to lose weight. Some of the tricks for that are just eating smaller, more frequent meals, helping to treat nausea and constipation. I mean, if you're constipated, you're not going to be hungry. So really making sure that we're managing nausea and constipation well enough so that people can eat better. In some cases, we do use appetite stimulants, but for those patients that are having a lot of nausea, stimulating their appetite and getting them to eat more food can just cause more problems in terms of nausea. So in certain cases, appetite stimulants can be very helpful. We can also use nutrition to help guide us in how many calories a day someone should be taking. Fatigue, this is a very common complaint of patients. adequate hydration is really important in helping to manage fatigue. Think about those summers when it's really hot outside and you're getting a little dehydrated. How fatigued do you feel? It's the same concept when you're on chemotherapy and treating disease. If you're not taking in enough fluids, you're going to feel more tired. You're going to have less energy. So, really being sure that you're taking in enough. It doesn't have to be water. I typically recommend to my patients any kind of liquid. Maybe it's a protein shake, and you're getting more bang for your buck out of that because you're getting calories and you're getting liquid. Um, Caffeine beverages, while they're okay, they can add to dehydration because they just stimulate your bladder. So you'll just be urinating more. Again, fatigue can be helped with proper nutrition, making sure you're getting protein. I have some patients that all they want to eat is ice cream. It's the only thing that tastes good. But if you're not getting in enough protein, you are going to be more fatigued. Making sure you're resting as needed and reducing work hours if needed. We're always happy to help with paperwork for people who need to take some time off from work to help get through their treatment. And then managing the psychological impact socially. People might feel isolated from their family and friends. They may have low blood counts because of the chemotherapy and treatment. And this may increase their worry about infection, so they become more isolated from family events. Loss of hair, loss of weight may contribute to feelings of being more self-conscious or worry that somebody is going to inquire about your health and not be feeling comfortable or being ready to answer those kinds of questions. Fatigue can, low energy can make it very difficult to go out. So, socially, it is important to keep these things in mind and making sure that you are continuing to find ways to be with your family and friends. Financially, it might be difficult to work while you're undergoing treatment. You may have low or poor coverage for leave from your employer. And our social service team can be really helpful kind of navigating what other resources out there might be available for you. Psychologically and emotionally, people can feel depressed from the uncertain future. They worry about poor outcomes. They have concern about their family being left behind if their treatment is not successful. And it can really play a huge role in how they feel physically if psychologically they're having a lot of these symptoms. Advanced care planning. I like to be in these conversations early on with patients. It is important to have a healthcare proxy, somebody who can, really make decisions for you. You should have a primary and a secondary healthcare proxy. If you're not able to make decisions for yourself, if you're hospitalized, you need to have a healthcare proxy identified early on. Advanced directives are legal documents that outline what types of life-sustaining treatments you want or do not want. And these include things like whether or not you want CPR, whether or not you want to have a breathing tube placed if you're having difficulty breathing, whether or not you want to be on a breathing machine or a ventilator, whether or not you want things like dialysis or artificial nutrition or hydration. So it is important to have advanced directives. I think it's important to have an advanced directive whether you have a diagnosis of pancreatic cancer or not, because no one really knows when they'll be in that situation. And a MOLST, some people will hear about a MOLST. This is a Massachusetts Order of Life-Sustaining Treatment, and this is actually a medical document. It's different than an advanced directive. And it contains actual medical orders that can be acted upon as soon as it's signed. And I do think, again, it's important to start these conversations with our patients and our families early. They're not always the most fun conversations to have, but I encourage people to make sure that you're planning for the worst while you're continuing to hope for the best. These are not decisions that you want to be making when you're faced with a life-threatening situation, like being hospitalized. So that concludes all the information. I actually did talk longer than I had hoped to, but want to take a minute or two to answer any questions that people might have.
Thank you, Laurie. If you have any questions, feel free to enter them in the chat for Laurie. We have a question regarding whether patients with pancreatic cancer need to follow a special diet.
I'm sorry, say that again. I was just checking my pager.
There was a question regarding diet, whether patients with pancreatic cancer need to follow a special diet.
Yeah, I mean, that's a great question. So, and it's really situation dependent. So, sometimes with the issues with digestive enzymes, there will be certain foods that patients won't be able to tolerate. Those typically will be the higher fat foods, fatty foods, fried foods. Sometimes going out to eat can be a problem because what's in the food is a little bit more unpredictable. So if you're somebody who is suffering from pancreatic insufficiency, then you do need to be a little bit more careful about what you take in. This is when our nutritionists can be extremely helpful because they'll do a very thorough nutrition history, taking a look at what kind of foods you're already eating, trying to help figure out which ones might be bothering you, and then give suggestions for how to avoid those and meet your calorie intake so you don't lose weight.
Thank you. What support is available to caregivers of patients with pancreatic cancer?
Yeah, I mean, we have a great support team, and I guess I sort of didn't get into this enough. We have an incredible team of social workers who really are very skilled and experienced at managing the specific issues that our oncology patients have, not just pancreatic cancer, but any kind of cancer. So they are readily available to us, and I typically will write a social work consult upon meeting someone for the first time, just so that they can do a meet and greet and make decisions for themselves about whether or not they want to continue with that support. We have a psych onc team, which is a team of psychiatrists and psychologists, also specialized in the specific issues that relate to our cancer patients. And we can make referral to them as well, especially if we think someone is going to be needing medication management for depression or anxiety. We have a palliative care team. And often I mentioned that word, people immediately think of hospice, but that's not why we use them. We use them to help with a lot of multi-symptom management, pain control, issues with sleeping, issues with nausea. We can place consults to them, and they can give us some expert guidance about what medications might be helpful. Nutrition. Up in our infusion unit, we have a massage therapist, we have an acupuncturist, both of which can be really helpful in managing symptoms of side effects of chemotherapy as well. We have a great team.
That's great. Thank you. We do have one final question. What online resources do you suggest for someone to learn more about pancreatic cancer, treatment, supportive resources available?
So I would encourage people to stay off of Google. I think that you can find a lot of dangerous information out there. There's a lot of blogs that are out there that those are the worst case scenarios. Those are always patients that had the worst experience sharing their stories and can often incite a lot of concern with our patients. I would encourage them to go to legitimate articles using the patient family library for resources. There are specific, pancreatic cancer awareness organizations, both online and in print form, that can be really helpful as well. So stick to the legitimate resources for information.
Absolutely. And as you had mentioned, we are a resource, the Blum Center. So feel free, if you want any information on a health topic, feel free to contact us. We're available through phone or email. I'll also put in our email address in the chat. It is pflc@partners.org, which simply stands for Patient and Family Learning Center. All right, so we are at time, but before we end today's session, do you have any final thoughts you'd like to share with the audience?
Thank you very much for having me.
Thank you, Laurie. And for
Yeah.
everyone who joined today, thank you so much. Hopefully you found today's session helpful. As I had mentioned, today's session is being recorded. It'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you, everyone.
Thank you.
Take care.
Bye.